Opportunity to chair this section. It's my pleasure to introduce Dr. Aravinda Jagadeesha. He is MD General Medicine and one of the few with triple FRCP from Edinburgh, London and Glasgow.
Sir, for the nice words. Good morning, everybody. At the outset, I thank Dr. Jyotidev, sir, for giving me an important oration, Kesadev oration, named after his father. I am very humbled and honored to deliver this talk, deliver this oration. So, diabetes in young, the new shift. It's a global challenge. When it comes to diabetes, it doesn't discriminate by age. So if you take youth onset diabetes, diabetes in young has been classically defined as onset of diabetes less than 35 years, like type 1 diabetes, type 2 diabetes, type 1.5 diabetes, that is LADA, ketosis-prone diabetes, that is flat burst diabetes, monogenic diabetes, that is maturity onset of diabetes in young, mitochondrial diabetes, that is maternally inherited diabetes and deafness, and other genetic variants, malnutrition modulated diabetes mellitus, recently termed as type 5 diabetes, fibrocalculous pancreatic diabetes, that is FCPD. There are other forms of diabetes in young, that is gestational diabetes, endocrine diabetes, genetic syndrome associated with diabetes in young, that is Klinefelter syndrome and Turner syndrome, secondary diabetes, no doubt, and stress hyperglycemia and neonatal diabetes. So the young onset diabetes, that is Indian perspective, diabetes in young has been classically defined as onset of diabetes less than 35 years of age. The most common etiologies for diabetes in young are type 2 diabetes 40%, type 1 diabetes 40%, fibrocalculous pancreatic diabetes, that is FCPD, depends upon the range, but in this study they found 15%, MODY is 2%, rest is 3%. An exponential increase in type 2 diabetes prevalence in India in the last 30 years has played a major role in contributing to the increased burden of diabetes in young in this part of the world. The prevalence of type 2 diabetes in India is 8 to 10%, with an additional 15% having pre-diabetes. This is a slide showing the differential characteristic of diabetes in young. First one is type 1, type 2, MODY and atypical diabetes. You can see a decay at onset. We all know that is type 1 diabetes is classical features. When it comes to HLA-DR3, the association is there with type 1 diabetes. When it comes to C-peptide, it is decreased or absent and it is variable in other condition. When it comes to acanthosis nigricans, very classical features of type 2 diabetes. When it comes to autoantibodies, which will be present in type 1 diabetes. So this is a slide which shows the differential characteristic of diabetes in young. So young onset diabetes, why it is important? Beta cell decline is more rapid in young onset versus late onset type 2 diabetes. Young onset type 2 diabetes has a greater risk of complications than type 1 diabetes. The risk of complication in young onset type 2 diabetes is high compared with the late onset type 2 diabetes, mainly due to a longer duration of disease. Worse glycemic and lipid control and higher prevalence of retinopathy compared to older onset type 2 diabetic patient. This is an important algorithm. If most of us keep in the clinic, it will help in diagnosis which type of diabetes you are doing. First, you can see at the top, the diabetes in the young, you identify that. There is a family history of diabetes, you ask for that. If it is positive, ask for whether it is present in 3 generations. If it is yes, then look for ketonuria. If it is negative, C-peptide is good, response to sulfonylurea, monogenic diabetes, classify subtype based on the genotype, that is MODY. So then when it is not there in the 3 generation, if ketonuria is negative, C-peptide is good, response to OHA is there, family history of diabetes in one or both parents, then it is early onset type 2 diabetes. If the family history is negative, if ketonuria is positive, C-peptide is absent, then it is type 1 diabetes. So autoantibody is positive, autoantibody is negative, that is autoimmune type 1 diabetes and idiopathic type 1 diabetes. Then there is ketonuria is negative, C-peptide is poor, asks for abdominal X-ray, look for the pancreatic calculi, then it is FCPD. Then at the extreme right, you can see the other endocrine disorders, brothers, that is endocrine diabetes, genetic defects, and the genetic disorder of diabetes. This is a simple chart which will help us in clinical practice. So we all know the management of type 1 diabetes. I am not going to deal with it because it is the basic insulin. So that is the typical management of type 1 diabetes. When it comes to management of type 2 diabetes in youth, there is a difference. You can see when the A1C is less than 8.5%, go for metformin, titrate up to 2000 milligrams. If it is more than 8.5, no acidosis, with or without ketosis, metformin and long-acting insulin. Acidosis is present, then it is insulin only. Ask for the pancreatic autoantibodies. If it is positive, continue insulin. If it is negative, continue or start metformin along with insulin. GLP-1 RA also can be considered in a young onset, youth onset type 2 diabetes. This is the management for this. Now when it comes to management of MODI itself a half an hour session. So there are different types of MODI. You can see here on the left hand side, there are various types of MODI, and the treatment option you can see starting from most of them requires diet, and most important to remember is most of them requires only simple sulfonylureas depending upon the type of MODI patient has got. This is a treatment approach for the case of MODI here. You can see the clinical features, age of diagnosis, sex, BMI, and duration of diabetes, treatment, current treatment, time to continuous insulin therapy, and family history. You take all this, look for the MODI probability calculator, MODI genetic testing. If it is HNF1 MODI, HNF4A MODI, low dose sulfonylurea. If it is GCK MODI, no treatment required. This is also important. If it is HNF1B MODI, insulin is the treatment. Why it is important is recognizing earlier and treating accordingly is very, very important. LADA, latent autoimmune diabetes in young adults, that is also known as 1.5 diabetes, typically diagnosed above 30 years of age. Polyuria, polydipsia, weight loss symptoms will be there. 10 to 25% of the type 2 diabetes diagnosis are in fact type 1.5 diabetes. So what is the proposed algorithm? Once the new diagnosis of diabetes is made, look for the clinical risk assessment, age less than 50 years, BMI less than 25, acute symptoms of hyperglycemia, history of autoimmune disease, familiarity of autoimmune disease. If high risk of LADA is there, that is more than 2 clinical features, measure GAD antibodies. If it is negative, type 2 diabetes. If it is positive, it is LADA. Measure C-peptide to define therapy. In the middle, you can see the mild risk of LADA, that is one clinical feature. Measure C-peptide, normal value, consider type 2 diabetes, low value, measure GAD antibodies. If it is negative, it becomes type 2 diabetes. Low risk of LADA, directly it becomes the type 2 diabetes. This is the simple algorithm which helps in diagnosis LADA. So how do you treat? It depends upon the C-peptide value, less than 300 picomoles per liter, commence insulin 300 to 700, use type 2 diabetes guidelines, more than 700, manages type 2 diabetes. So coming to FCPD, patient should be from a tropical country, diabetes should be present, evidence of chronic pancreatitis must be present like abnormal pancreatic morphology on sonography or CT scan, absence of other causes of chronic pancreatitis like alcoholism, hepatobiliary disease. Although patients with FCPD or insulin deficient and require lifelong insulin therapy, they rarely develop diabetic ketoacidosis. Abdominal imaging by plain X-ray or ultrasonography is useful in detecting pancreatic pathology in cases of FCPD. So ladies and gentlemen, now in the next few slides will be on how the things are changing in our country as well as in the globe. On the left hand side you can see the modifiable risk factor, that is maternal obesity, weight gain, GDM, diet, smoking, paternal obesity, What is the possible pathomechanisms? Stem cell differentiation, beta cell differentiation, genetic programming, epigenetic changes. In the middle section, C-section, low birth weight, no breastfeeding, rapid weight gain, early solid food introduction, antibiotics, passive smoking. What does that happen? Adipose tissue expansion, gut microbiota changes, epigenetic changes. On the right-hand side, which we are seeing rapidly, that is high sugar intake, lack of exercise, increased screen time, early rapid weight gain, lack of sleep, smoking, leads to increased visceral fat, increased insulin resistance, increased adipokine, vascular changes, systemic inflammation. All these things leads to obesity and type 2 diabetes. I'm sure all of you are agreeing, even in Kerala you are seeing this type of changes in a day-to-day practice. So what are the challenges? Causes, challenges and prevention, like childhood, teenage, adulthood, after marriage, before pregnancy, during pregnancy, post-pregnancy, lactation, elderly. You can see the life cycle of a person. All are interconnected here. So just to take an example of this lady, how the things are changing nowadays in our country and as well as in the globe. This is a 25-year-old software engineer juggling a 9 to 6 at a big IT firm. Among the daily hustles of Metro City, she is a workaholic by nature, working from 9 a.m. to 9 p.m. So a day in life of Emma, that imagine that lady is sitting in front of you and talking to you like this. So increased stress and screen time, increased consumption of processed and non-nutritious, essential, accessible food, easily accessible food option, no to least physical activity, weekend jibes of alcohol and salty food, increased nighttime mobile phone use and sleep deprivation, lethargic and therefore indulge in excessive caffeine throughout the day, improper food habits and snacking on a packaged food with soft drinks replacing water. So there is a lifestyle dilemma in the current age, isn't it? I am sure all of you will agree. The individual health factor you can see, genetic predisposition, genetic syndrome, prenatal exposure, epigenetic changes, mental health and learning disability. On the other side, social determinants like socio-cultural differences, endocrine disruptors, deprivation and environmental pollutions. In the middle you can see the main thing is increased activity, increased calorie intake, adiposity, all leading to early onset type 2 diabetes. This is an epidemic which is going on in our country. So Indian youths at high prevalence of diabetes. The Registry of Youth Onset Diabetes in India, if you see the rationale and recruitment and the current status, 25% young adults in India that is below 25 years of age has type 2 diabetes, which shortens their lifespan. This is a 2016 article, but it is still relevant. So it is increasing by 5% every year, the incidence of youth onset type 2 diabetes. So if you take this lady's lifestyle choices has entered her into a fierce of metabolic tango. Means without her knowledge, she is entering into the metabolic tango. She is a busy lady. So she has she is having obesity, like BMI of 25, HbA1c of 6.4, blood pressure of 130/90. Unfortunately, she may have progressed to the asymptomatic phases of metabolic progression, which she is not aware at all. So estimated 44% of the adults living with diabetes are undiagnosed. Undiagnosed and untreated hyperglycemia result in increased risk of complication. As she starts a family, just she wants to get married, now she wants to start a family, still her unchanged lifestyle habits will now inadvertently have an impact on her progeny's health. In a meta-analysis study 2 years back, the association of pediatric metabolic syndrome with maternal metabolic syndrome was stronger than that of paternal metabolic syndrome, and that with both the parents was stronger. The stronger lifestyle association of children with mothers than those with fathers might be related to this difference. So she gets married, and she, during her gestation period, now dances through the pain of metabolic tango as the gestational diabetes. Now she was a software engineer, married, become pregnant, now the gestational diabetes is the risk factor. So the maternal hyperglycemia increases the child risk of long-term complication. Why? See, you can see in this article, the association between birth weight 4,000 gram or greater and perinatal outcomes in patients with or without gestational diabetes. Children born to mothers who have GDM have nearly twice the risk of childhood obesity and metabolic syndrome compared with children born to mothers who do not have GDM. Gestational diabetes is the forerunner for the development of maternal and childhood obesity and metabolic syndrome. So children born to these obese mothers who have GDM are more likely to develop type 2 diabetes than are children of non-obese mother without GDM. So there is a generation link. So the child is born. What happens? The parental behaviors, including diet and exercise pattern, influences the risk of metabolic disorders in the offsprings. So genetic predisposition, Emma's lifestyle during preconception and gestation, see her lifestyle is like this. So the inborn susceptibility to the cardiometabolic disease, you can see the potential mechanism over there. So once again, a cycle begins as the next generation inherits not only genetic predispositions but also the lifestyle habits. So the maternal lifestyle influences the fetal development. You can see because of the maternal lifestyle, nutrition, stress factors, all this leads to an adverse effect on the fetal brain development, fetal compartment. You can see the external environment. All these things are there. The child is born. The newborn structure and function, she is more than 4 kgs, and people will feel happy that their children is more than 4 kgs. Is it good? We have to retrospectively think on ourselves. So the maternal legacy, the dance begins once again. The sedentary lifestyle and poor dietary habits during pregnancy set the stage for a metabolic tango, as her child not only inherits genetic predispositions but also acquires a taste for the lifestyle patterns imprinted in the womb. This has to be very clearly kept in mind. So the dilemma is she is influenced once the child is born. What happens now? Next is the another factor. She is influenced by the societal pressures and concerns about maintaining a certain cosmetic image. So she hesitates to embrace breastfeeding. Her journey reflects the delicate balance between external expectations and the fundamental needs of the newborn, adding to the another problem, another legacy. So you can see the breastfeeding benefit. So there are so many breastfeeding benefits. The effect of breastfeeding and formula, when compared, it reduces the incidence of type 2 diabetes and metabolic and cardiovascular disease. Risk of not breastfeeding for mothers and infants, you can see the increase in type 2 diabetes. These are the various studies which emphasizes the importance of breastfeeding, which this lady is hesitating to maintain her body figure because she would have seen the film actors. So that is the thing, and societal pressures, societal appearance, all these things happens and she is not breastfeeding. So you can see in this slide how the metabolic programming happens. Maternal diets, maternal metabolic status, maternal behaviors, infant formulas, metabolic programming, all those neuronal disorders, all leads to obesity, insulin resistance and diabetes. See how the cycle is going on in a simple software lady because of her lifestyle and societal pressures. So the childhood pressures is the inherited melodies. As Emma's child grows, the echoes of the metabolic tangos becomes more pronounced. The child is following the maternal habits, maternal things are going on. The cycle gains momentum with each passing year, embedding these habits deeper. The child is also following the mother's habit. So the teenage symphony, the birth of a new dance. A child, now a teenager, faces the consequences of metabolic tango. So the child is born, everybody is happy, but the child is having a metabolic tango because of the maternal habits. So inherited lifestyle factor, inherited genetic predisposition, peer influence and the societal norms, and the obesity. The formation a new unique dance, that is metabolic disorders of the past, merge with the contemporary lifestyles, fueling a vicious cycle. So the youth onset type 2 diabetes, the epidemiology of an awakening epidemic means it is showing, once again the area is emphasizing there is an increase in incidence of type 2 diabetes. The vicious cycle of a metabolic tango persists for generations, having the direct impact on the rate of increasing young onset diabetes. You can see here how the cycle goes, or the vicious cycle of diabetes, like obesity, PCOS, preeclampsia, hyperglycemia, like how the things has gone, happens in a woman with GDM. So how to break the dance? It's only a glimmer of hope we can do as a doctor along with the government support. Steps to break this cycle: lifestyle management and weight control before and during pregnancy, appropriate gestational weight gain due in part to concerns about the increasing prevalence of obesity in reproductive age women, empowering mothers with information on making healthier choices during pregnancy, providing resources and strategies to support a positive and nurturing intrauterine environment, encouraging women on breastfeeding and improving awareness on the benefits of breastfeeding for the mothers and the child. Awareness is key to early detection and intervention. We can do in-clinic poster education and counseling, pamphlet and ads. Even Pradhan Mantri Matru Vandana Yojana is there, where the government schemes to improve the maternal and child health is there, which we have to make aware to our patients to use these facilities. Risk factors for diabetes in India, you can overall, if you take, these are the modifiable risk factor, like physical inactivity, overweight, obese, poor dietary habit, hypertension and smoking. Non-modifiable risk factor, which is not in our hand: genetics, family history, race, increasing age and history of gestational diabetes. Last two slides. The lifestyle modification is very, very important. Increase physical activity, develop strategy to manage stress, form and maintain relationships, improve your sleep and cessation of tobacco. Most important is healthful eating. So quit smoking and alcohol is very crucial. In a bid to tackle lifestyle disease in the country, many countries in the world have special taxes on the junk food to curb ballooning obesity in other country. Why not in our country? This is a thought. So fat tax as a way to reduce the number of diabetes cases in young people, to prevent McDonald's from make diabetes. Burger King, you can see that I am the new Burger King. The consumption of junk food should be stopped by education. From RSSDI, our advice to a policymaker, the 4 I's, if you take, increasing the restriction on the advertisement of unhealthy foods to children, improving school meals by developing the binding quality standards for the catering offers in the preschools and schools, implementing a sugar or fat tax to reduce the consumption of unhealthy foods, increasing daily physical activity by offering more physical activity sports in schools and preschools. To conclude my talk, ladies and gentlemen, there exists intricate connections between lifestyle, metabolic health and gestational diabetes. By understanding and addressing these factors, we can break the chain and create a healthier future for the generations to come. The generational metabolic tango initiated by maternal lifestyle choices can be a relentless cycle. Through awareness, education and proactive intervention, we can write the choreography of health. Breaking free from the dance of metabolic disorder is not only a personal trim, but a legacy that paves the way for a healthier, harmonious future. Thanks, Dr. Jyotidev sir, once again for giving me this prestigious Kesav Dev oration. Thank you, sir. Thank you for one and all.